TV, turning on your world.
Good evening and welcome to the show On the Spot. My name is Patrick Amara. On Monday, Cabinet approved draft National Health Insurance Scheme to be presented to Parliament. The bill seeks to introduce a mandatory contributory scheme aimed at ensuring the national population against high and unpredictable costs in health care. But how will this scheme work? Tonight on the Spot, I have the Minister of Health, Dr. Jane Ruth Acheng, and Dr. Lulume Bayiga, former MP, Buiko South constituency. But first, let me make this preamble in a story.
The National Health Insurance Scheme is intended to facilitate the provision of accessible, affordable, acceptable and quality healthcare services to Ugandans irrespective of their age, economic, health and social status. Sarah Byakika, the Commissioner for Planning, Financing and Policy in the Ministry of Health, addressed the press in Kampala.
So even the accredited providers, they'll ensure that they efficiently and effectively utilize the available resources to ensure that the population can access quality health services.
If passed into law, it will be mandatory for every Ugandan above 18 to pay for health insurance.
In case of a person whose income is derived from salaried employment, a monthly deduction will be made from your salary by the employer, and a contribution will also be made by the employer to make your total contribution.
Dr. Frank Asimwe, a urologist with the Mulago Hospital, says the policy is long overdue.
For starters, the hospitals will have money available to use, depending on how they play it. So that even if an unknown patient, poor patient, one who has been brought by the police is dumped into your care, there will be some drugs in your store for you to begin rolling things.
And in case of a person whose income is derived from self-employment, whom we call the informal sector largely, they will make an annual contribution in a manner and a rate as may be determined by the regulations that will be made.
Asimwe points out that some clauses that give relatives and friends a chance to save their loved ones must be incorporated into the bill.
There should be a clause where someone can donate a balance of their insurance premium for that year, and if their relative is sick and the money on their card is not sufficient, one or two of the relatives who have got a good balance or any balance on their card, they can come and donate either the balance or some sum out of their cards.
It is not certain when the bill will be presented to Parliament.
What is critical really is the discussion is now going to begin for purposes of enacting the law.
The scheme had been projected to start in the 2018-2019 financial year. Currently, about only 200,000 Ugandans have private health insurance. As the nation takes this new dimension to cover healthcare from the grassroots level to the utmost level of this nation, many queries have been raised about the scheme. But in the region, it's only Uganda that has not subscribed to this policy. Andrew Chamagedo, NTV Tonight.
Andrew Chamagero, thank you very much indeed. And that gives us a preamble so that we can start a discussion on the issue tonight, on the National Health Insurance Scheme. And my guests, I have the Minister of Health, Dr. Jane Ruth Acheng. Thank you very much for honoring our invitation. I have Dr. Lulume Bayiga, former MP, Buiko South constituency, and former Shadow Minister of Health. Welcome.
Thank you.
And both of you, a warm welcome to you. Let me begin with you, Dr. Cheng. What is this that you want to propose for Uganda?
Well, what we want to propose for Ugandans is a comprehensive national health insurance scheme that covers for all the citizens of Uganda. we are all very much aware, and let nobody be deceived, that health services are not cheap. And health services can never be absolutely free. In many of the countries surrounding Uganda and worldwide, people insure their citizens for health services so that when they want health services or when they need it, they can access it at any time. Health services in Uganda here have been said to be largely free, but it is not true that it is absolutely free. People are paying out of pocket, and our national health accounts clearly indicates that 41% comes from out-of-pocket expenditure, which is quite high, and it drives many households into impoverishment because they have to sell their properties to access health services. But when we have national health insurance, then we have what we call risk pooling, where we subsidize one another, because not everybody will utilize health services all the time, and not everybody will pay for health services all the time. And so we can subsidize the very poor so that they can also access quality services, even as government continues to improve infrastructure and improve many of the other things that are required to ensure that we have quality services. National health insurance is the way to go if we are to achieve universal health coverage.
Dr. Cheng, you've just said out-of-pocket accounts for about 41%. And I understand 42% is donor funded. And understand 15%, only 15% is what is coming from government to the ministry for the healthcare. If this was a business, the government is a minority shareholder. Why would you want to bulldoze the majority of those who are having 41 and 42, yet the government only puts in 15 in the healthcare system?
Very interesting question. First of all, allow me to inform you that our total expenditure on health is about 7.3 trillion. And we know very well that our revenue collection only approximate about 30 trillion. And so if you take away 7.3 trillion and we operate a cash economy, what is left for government to spend on the various other services? So there has to be a balance. And government expenditure on 15% is relatively good for health services that are free for the people. We know very well that donors have invested heavily, and you're absolutely right that 40%, to be precise, 42% comes from donors. But will donors continue to support us forever? Will donors continue to subsidize our health facilities and our health expenditures forever? No. There will come a time when donors will withdraw, and they've started withdrawing from many of the expenditures that they are invested in heavily. And so we need to plan ahead as a country and find means of ensuring that our people continue to receive services and receive quality services. And the only way to do this is to go national health insurance, because our people deep down in the villages, those people in the community, also deserve quality health care. But are they accessing it? That is the question that we want to answer here, so that me and you and they can access the same quality services anytime that we need it.
Dr. Lulume, you are a medical doctor, you are a member of parliament at one time, also minister, shadow minister for health. Is this what the proposition they are making now? Is this the magic bullet?
First of all, I want to congratulate the Ministry for Health for coming out with this bill, and I think it has taken over 17 years.
Yes.
And everybody was waiting for it to see how it can help in health financing. And a lot of debates have been going on. And many members of parliament, people from Ministry of Health have been benchmarking
from various countries where they are implementing some semblance of a national health insurance scheme. Whether it will work or not is another topic for, it's another discussion. But to have a discussion of how health insurance can work in Uganda is a very welcome topic. The most important thing that we need to address is whether or not third world countries, which have the apex of the taxpayers being only 3%, can they be in position to finance the 97% of the population, which is largely poor and in informal sector? I think that is where the bottleneck is, and
Okay,
where that's
so
the
yes,
discussion.
then Dr. Cheng should be able to tell us where the unemployed, the jobless generation of Uganda is going to get money to put in this system so that they too can partake of this health insurance scheme you're proposing.
That is exactly what we are trying to address, because as you know, with health insurance, it is about risk pooling. As we have proposed, and this is yet to be debated by Parliament, we have proposed that those who are salaried, those in the formal sector, contribute 4%, and their employer, either government
Do you
or any
understand the
other.
burden you're putting on a Ugandan worker that is already paying a lot of, because to me this also looks like another tax.
To tell you the truth, even those who are in formal employment pay for their health services. So a contribution of 4% and getting a top-up from government of 1% is an addition to what you're already paying. Many, many people pay for their services. We need to face the reality. And we are saying those that are self-employed contribute 100,000 per year. I am very sure that they spend much more than that in their daily seeking of health care.
So that you're meaning that lady who is frying granules in that market somewhere in rural Uganda should be contributing 100,000?
Not exactly, because...
That is also some form of self-employment.
Exactly, but what we are saying, we shall also calculate this depending on the income of the person. That is a suggested figure. It will vary according to the income of the person. We are also going to look at the various surveys that have been carried out by Ministry of Finance in the poverty index that will define what households really get and that kind of household that you expect to really have low. We have also gone ahead to grade people as indigents. And in our definition of indigents, we have people who don't have any income at all. We have people who are disabled, and many others.
People without an income, Dr. Cheng, that is a big population of Uganda.
Exactly.
So
and we are saying this group of people will not make a contribution because government will support initially to kickstart.
Okay, so let me put this
and then
question.
we will enroll them
but
on.
just let me understand this.
Yes.
These indigents, if they who are not employed, perhaps we can say most vulnerable people, maybe they are even disabled. So can somebody come to Nakasero Hospital or any of these topmost hospital and then get service because of through this kind of scheme?
Exactly. This is what we are saying.
And you expect that the service providers will accept the government card to come and treat this person in the top-notch hospital in Kampala? Because there's an element of trust, a lack of trust with the government of Uganda.
I know, absolutely, but let me tell you, if there is any institution that pays, government will always pay its bills. There may be a delay, but government pays. So what we are saying is the indigents, the very poor people, the orphans, vulnerable children, older persons, persons with disability, destitutes, refugees, through this risk pooling, they will be assured of getting their basic health services. And we are looking at the minimum health care package.
Okay.
We are not looking at the ultimate, like somebody wants to have a renal transplant or kidney transplant for that matter.
So when you talk,
That is
about
way
the minimum,
above.
when you talk about the minimum, what do you mean, Dr. Cheng?
There is a defined package that will be accessible through this health insurance scheme. And this package includes surgeries, it includes the other health care, which is medical, it includes dental services to a certain degree. It is well defined, and it is attached to the bill.
When diseases decide to strike, they're not going to strike at a certain minimum. They will strike anyway, whether you are rich or poor.
Exactly.
They can hit you hard no matter your situation.
Exactly.
So why are you saying we're only providing a certain amount, as if you expect what diseases?
Because this is for basic health services.
Okay.
Now, when it comes to the more specialized health services, Mr. Kamara, there is no country where you will go to and get the specialized health services free of charge.
Dr. Lulume, is the issue in this healthcare system about money or the lack of systems and issues of management? Is it really about money?
Well, we shall continue to scrutinize government expenditure on health. And I think government, in absolute terms, we're talking about 7.3 trillion, but as compared to the national budget, certainly the expenditure goes on lessening. And of course, the cost of living and how expensive things are also determines what comes into health. Therefore, money per se is a predictor of what kind of health services that we get. So government has failed to make a good contribution to healthcare delivery, and that is why you see 41% of the expenditure, national expenditure on health, comes from the private pockets. So the assumption within the bill would be whether you can mobilize the 41% of that expenditure and put it in a resource envelope. How you're going to do that, that's another debate. I don't think that the merits of having an insurance scheme cannot be really debated. It's very important. But in our countries, in those countries where health insurance has worked, you will have a population, 75% of the population are taxpayers, and big taxpayers at that, and therefore can provision, not provide, to provision for the 25% who are indigent. But you have a population where you have 75% indigent, and they must be provisioned by only 25%. Can that work? That is the gist of the debate.
What happens? You are a corporate Ugandan, you have a health insurance scheme, all these top-notch hospitals are available to you, and then you bring this national health insurance scheme. Do I also pay the 4%, but also continue with the arrangement I've always been had, or that arrangement has to go away?
Well, this is a national insurance scheme, and it is mandatory. Everybody in the country must enroll onto it for the basic healthcare services. Now, for the more super specialized services, you have to enroll onto a private scheme. Because if you want to have a heart transplant, or you need to have a kidney transplant, those are super specialized surgeries that are extremely expensive. And your contribution, the kind of contribution I'm talking about, cannot afford such services. And so such services have to be paid for through another scheme.
Dr. Cheng, if you're aware that today in Kampala, God forbid if somebody fell sick or your loved one fell sick, if you went to hospital, and these, I won't mention them, but you know them, if you went there for only 5 days, or you're admitted for about 10, you'll slide back into poverty because the bill that is going to come from there is huge. And even before you bring this insurance scheme, you've been presiding over that kind of system. And one wonders.
Ex-
I have a friend of mine who's been hospitalized on IHK. Okay, now I've mentioned it, but the bill is astronomical. And I'm wondering, there's a Ministry of Health, there's a government. What is it that you doctors are giving us in these hospitals that when we come for only 3-4 days, then we have to slide back into poverty forever?
Well, you have a choice to make. Like what government usually tells our peasants, that if at all you don't want your child to go in a UPE school, then you must make a contribution and take to a private. No, that is what this government
I have a
says.
choice to make when I'm sick?
Yes.
I don't have a choice.
You can have
No, please
food.
don't. You can't say something like that.
Give me a chance. You can have food, and I'm a general practitioner.
I know.
So I'm a private practitioner, and that is how I make my living. You can come to KIMC where I work. You can go to IHK or KES for the same illness to see the same doctors who studied in the same university. So those certain people, we call it a snob effect. They would want to go into certain hospitals where Dr. Ruth Acheng has gone, simply because Dr. Ruth Acheng studied with them. But you can have a choice to go to other spaces where you can, where your pocket can.
So the prices that we see now are wholly justifiable, right?
Mr. Kamara.
Certain people would also want to fend off certain numbers. Say, okay, a certain consultant, Dr. Ruth Acheng, is here, and he is working, and everybody wants to see her. Say, okay, my consultation is going to be this astronomical. Those, the Kamaras who want to continue to see her, will pay. And those who will not, then will say, okay, let me go to Dr. Rulume's place.
Does the cost,
Mr.
before I even
Kamara.
get this, because you are the Minister of Health, and I know perhaps you want to cure this kind of problem, does it really
let
concern
me
you?
answer that question.
Yes.
That is exactly what we are trying to cure through having a national health insurance scheme. Because the health sector is largely unregulated. Many of the facilities set their own prices. And that is why you have friends, relatives, and in-laws paying astronomical sums. And as you have correctly said, it pushes them into poverty every now and then. So what is the cure to this? We need to have a streamlined way of collecting fee and prepaying, so that when you need services, you walk into that hospital and you get your services. And by the way, when we have a national health insurance scheme, we are looking at numbers, because the private sector, which by the way only contributes 2% to the total health sector expenditures, charge people because they may not have the numbers. But once you bring in a national health insurance scheme that is mandatory, and everybody is free to go wherever they choose to go, and you know very well that if you set your prices high, people will not come. So you will be forced to lower the prices so that you can have the numbers and get the money.
You know, majority
So
of
it becomes-
Ugandans, Dr. Cheng, maybe you know that more than I do, are accessing healthcare services from Health Center 3.
Yes.
And where's the focus of government? You're focusing on building an ultra-modern hospital, now mired in controversy somewhere in Lubowa, and putting $1 trillion something money there. And yet, you could have focused on Health Center 3, where over than 70% of the people are, and make sure the system there is robust and it's working. I visited one hospital, and I only found one lady working on about 80 mothers, somewhere in Amuru. I just couldn't believe it. The truth is, the Ugandan health worker, like you and him, have not abandoned ship, but they have just been improvising because maybe they love their job. But you have really not given them tools. So this money, is it also going to be to enhance health workers' salaries, buy medicine, capital development? Where does it go?
I will start from your point of the Health Center 3s. And it is good you raise it, because as we all know, primary health care is extremely important. And when we emphasize on primary health care and disease prevention, then we address the 75 disease burden, which is our problem in Uganda. And to address that, government has invested a lot this financial year coming to an end, for the next 4 years, to improve on the health center 3s. We are upgrading the health center 2s in the sub-counties to health center 3s. In this financial year, we have worked on 124 of them. We will continue working on them until we have upgraded all of them. Immediately, a health center 3 is upgraded. It is equipped, and it has money for medicines, as well as health workers recruited. By 2021, we want to ensure that all the health center 3s in sub-counties are functional to capacity.
There was a
provide
World
services
Bank
to the
loan or grant that was supposed to work on those older hospitals and refurbish them and equip them. But also, I'm told there was also money which was supposed to train the health workers. I wonder whether that was actualized.
Yes, the current funding we are using for those health center 3s is a World Bank loan. And it is meant for the health center 3s upgrade. We shall also construct health center 3s in sub-counties where they don't exist. However, government is also working on ensuring that all our regional referral hospitals are equipped to capacity.
Okay, Dr. Lulume.
And that will be realized very
Dr.
soon.
Lulume, when you go to some of those villages and look at health center 3s, yes, Dr. Chen can say we have the brick and mortar, we have the buildings, we have the structures there. But in most cases, you'll find the personnel are not there, medicine is not available, and that's what we need. In most cases, we don't want, okay, capital development is good, but at the end of the day, I need to find a Dr. Lulume to work on me. I need to find a Dr. Lulume who's not overwhelmed. Like I saw a midwife in Amuru who was overwhelmed and working alone, though I put off my heart for her because she was handling and she had to stand her guard. But that's not what
you see
should be.
You see, Dr. The Minister of Health, Honorable Minister of Health, our argument, even when I was Shadow Minister for Health, was about universal health access. And that one carries with it government's commitment to provide for health care through an expenditure, to tangibilize this expenditure. You cannot wish it away. And what you are explaining about functionalizing health center 3s and helping health center 2s to become health center 3s is actually aiding universal health access.
Yes.
Now, when it comes to the proposed national health insurance bill, I was imagining one person in a deep end of a parish who was accessing a health center 2 level to pay 100,000 shillings proposed in order to be enrolled on the insurance scheme. The question is, where is he going to access this health care? He's going to travel 15 kilometers away until he gets on the health center 3, which is now getting refurbished, maybe, in order to access the services that have been accessed even without paying the 100,000 shillings per annum. So this one would be frustrating, certainly, unless we do that investment, and it must be deliberate. It must be deliberate, because we don't want to see this insurance scheme, which has been debated over and over for over 17 years, to be an escape route for government's failure to make deliberate attempts to ensure that the current system works by commitment of finances to enable it to work. When you people talked about the 15% as a budget declaration, it was real. And if at all it had been done for the last 10 years, we should be having such a semblance of a functioning health system, health care delivery system, where you will be having very well trained doctors who you have a lot of them, but are not really deployed enough to ensure that they functionalize these health center 3s. Very well trained nurses and very well motivated nurses who are going to functionalize them, and the medicine. You will be talking about the preventive health care, which is always proposed in the policy statements. And I don't know where it gets lost. It gets lost because that was my quarrel when I was Shadow Minister for Health. Talk about community health, and then they give you a perennial 3 billion shillings to cater for the whole country. And I believe if at all I go back to those books, I'll find 3 billion for community health. But this is the gist of the matter, to prevent people from getting sick.
Okay, we're going to take a break, and when we come back, let's look into that issue. You seem to be looking towards curative instead of being preventive area. Of if you go into preventive kind of a service, probably that would be better than going curative, because that's very expensive. Let's take a break and we'll be right back. Welcome back. You're watching On the Spot. My name is Patrick Kamara. My guests tonight are Honorable Dr. Jane Ruth Acheng, the Minister of Health, and Honorable Dr. Lulume Bayiga, former MP for Buikwe and Shadow Minister of Health. And we're discussing the proposed National Health Insurance Scheme. I understand you're also proposing to have a board, some kind of that will be running this. Again, I see a lot of money now is going to be sunk in this kind of board. You have regional offices. Why don't you run it through the ministry, not just having another board? Because
well, Mr. Kamara,
that will swallow a lot of funds.
As you correctly observed, we have proposed a board, and we have proposed a board because we also need to invest and generate more revenue. If we run this through the Ministry of Health, then we are not going to invest and generate revenue. We need to have more revenue come in to continue subsidizing the very poor. And so we'll have a very highly specialized board to run this. Now, while this board is based at the national level, we need to have a way of reaching out to the different regions and communities in Uganda. Because you cannot sit at the national level and you expect people to come in and roll. There has to be a way of attracting people to enroll into a system that is nearest to them. And that is why we are proposing the regional offices for the health insurance. Now, these regional offices will work with the community-based insurance people that will identify the people and have them enrolled into that system, so that the national level can concentrate on giving guidance to the regional level, but also on investments. And that is why we have a very specialized board.
Do you realize there's some kind of a trust deficit from the people of Uganda to some of these public institutions, and you create another, people don't have trust?
Well,
that you can, first of all, collect the 4% that money, and you know, after that, put it to better use. Effective utilization in this country is a big thing to ask.
You know, trust is built from the kind of services that you access. When you pay your money and you access quality services, then you begin to trust
with the little
system
that is available in our health system. We would already have seen that you are utilizing the little fund from government well. You'll go to some of these hospitals. I was in one hospital and I could see doctors, you know, at the entrance of an operating theater, people are using charcoal stoves because the autoclaving machines died long time ago. In some cases, I saw an incubator that was improvised. Somebody is putting something like another charcoal stove. Now, if we give you money, how are we sure that really you are going to use this money effectively, even when we see that the little that you've been getting as a ministry has not been to proper use? You're going all of a sudden now to learn to be effective?
It is not that we are going to all of a sudden learn to be effective. First of all, let me state here that for a facility to offer insurance services, there will have to be accreditation. and the facilities will have to change their ways of managing things. Because once we have the insurance scheme working, there will be money generated that will enable those facilities to improve. And for them to improve, we need good managers, we need leadership, we need people with business-oriented minds to change the entire arrangement of the systems. This needs money, and that is why we are saying, let's go insurance, so that you prepay, and we have that money to do that. However, we are also saying, for those that want more expensive services, there is another category of insurance that also needs to be rearranged. And that is what is currently going on all over the country. For the specialized services, you have been hearing us creating specialized services, specialized women's hospital, Mulago specialized. We are having the international specialized hospital, the regional pediatric hospital, and so on and so forth. This is to cater for the super specialties. But our major problem in Uganda are the preventive issues that we have not yet addressed, which forms the bulk, 75%. And we are also working on that. And I have been telling you we are improving on our health center 3s. We are giving them more money. We are putting their equipment, and we are recruiting staff. By the way, you may be pleased to know that of recent, government increased the salaries of health workers. And again, this coming financial year, the salaries of specialists have been increased. Again, when all these structures are concluded, more human resources will be recruited. Already we are working on a restructuring so that all these people that are out on the streets are recruited into the system.
Okay, Dr. Lume, when you look into the area of HIV and AIDS, almost 90% or more of the care and health services rendered there is foreign funded.
Yes.
And what government that outsources the job of keeping its people alive to another country?
And that was another quarrel. Because before you became Minister for Health, there were 3 others who were there, I think. And I had made a proposal that there should be an HIV fund, so that everybody, every able-bodied Ugandan, I proposed 10,000 shillings for beginners, and that was going to make 36 billion. If at all every able-bodied Ugandan above 18 paid 10,000 shillings for beginners, because we have always been worried about the unpredictability of health finance, especially in HIV realm, because it can be even a tool of control of third world countries, including ours, by donor communities. They can decide to control you because you have already enrolled people on treatment, and they say we no longer have money if at all you don't do this. If you don't sell us this, we are going to withdraw that. So we wanted the Ugandan government to be in charge of providing HIV care by our own selves, by introducing that kind of a tax. Of course, government rejected it, but they didn't replace it with any other proposal. But now that the minister is here, I'm putting it to you that you can make use of it, and those in the opposition would be able to support that kind of initiative.
It is not absolutely true that government rejected the HIV Trust Fund. Actually, the HIV Trust Fund, which was approved by Parliament, has been concluded. The regulations have been worked on and concluded, and we are now in the process of opening an account, and we begin collecting the monies for the trust fund. However, you may also be pleased to know that government increased its funding for HIV by 50%. So government's contribution for medicines for our people on HIV treatment has been going up every year. Every year.
Yeah, but 50% of what?
Well,
Because-
we are now at $30 million US per year for medicines, for patients. All countries in Africa get funding from the Global Fund to support their HIV response, TB, and malaria. All countries in Africa depend on PEPFAR to contribute to their HIV response. So it is not only Uganda that is heavily dependent on donors. However,
So that
Uganda
means
has
what?
been
That-
progressively increasing its funding with a realization that in the near future, the donors will withdraw and we have to take over. And government has been very cognizant of this and has been putting in place mechanisms to address the inevitable when it eventually happens.
How much do you budget in the healthcare for an individual per year? I don't know whether I'm being clear.
Are you absolutely clear?
Okay.
Currently in Uganda, we spend US dollars 53 for every individual per year. The recommended would be about $84 per individual per year. We shall get there.
So how come there are other countries in the region, I'm told Ethiopia, that is putting about 23 or thereabout for an individual per year, and they seem to have a better healthcare system, if it was a question of money?
Well, I cannot talk for Ethiopia, but I know their healthcare system is heavily dependent on their community health extension workers. And also, they train a lot of what here we call clinical officers. But in Uganda, you train the actual doctors and the specialists. Now, their investments in the community health extension workers has enabled them to address the high burden of communicable diseases. Because the community health extension workers, who are the first point of reach of any patient, are moving through the communities, giving information on what can be prevented
That's like
and
our
how
VHTs,
to prevent
the
it.
village health teams.
Exactly, but our VHTs are not motivated.
So
The
Dr.
ones of
Cheng,
Ethiopia
Dr.
are
Cheng,
motivated.
if
They are
not
paid,
you,
they are
the
on the
minister,
salary.
If not you, the minister, and the government of Uganda, who is going to motivate the VHTs?
Actually, one time
Actually,
I was
to tell you the truth, the Ministry of Health already developed a policy and a strategy for us to have community health extension workers who are paid a monthly allowance. It is still in discussion. Eventually it will come to pass so that they are as motivated as the ones in Ethiopia. We are addressing health promotion and prevention and setting up a system where we communicate on a regular basis to the entire population. Because if we can get people to do hand washing, if we can get people to sleep under mosquito nets, we have already made significant progress in reducing some of these preventable diseases. We only need to move a step further and they will all come down. Then we can concentrate on the non-communicable diseases.
I can agree that in the area of malaria, government has done a good job. I think the incidences of malaria have gone down.
I think you should also add HIV there because we are on track.
Yes, they have gone down, and I think really maybe I don't know what is the prevalence of rate of malaria nowadays.
We are now at about 16%. Kampala is at 1%.
So in other words, you can hardly get somebody suffering from malaria in Kampala.
In Kampala, it's very rare to get somebody suffering from malaria.
That's right.
So I still want to know, if a government failed to maintain the health facilities that we had, the big hospitals that you have recently renovated, you'd go to a hospital and you find it is totally run down. It's a hospital that used to have running water, it doesn't have running water. And then you wonder with all that infectious material and there's no running water. I know of a hospital that was digging pit latrines everywhere until they ran out of space. And then you wonder, if we do not know how to keep our things, we do not know how to maintain and care for what we have, how is this health insurance scheme going to change things?
Management and leadership. That is what we require. The majority of our health facilities are struggling with leadership and management issues. And some of those that you talk about that run without water It is actually leadership. But the funding is there. Government provides funding for water every financial
I went
year.
to one district hospital and there's no water and everybody's just going, there's only one borehole and all the caretakers, they just come and line up. You find about maybe 50 people in a borehole with over 60 jerrycans. Doesn't that really...
The funding is there, but it is very little.
So
the PHC fund, I don't know whether this was increased.
The PHC funding was increased by 50%.
By 50%?
Yes.
From 1,200,000. So by 50%, that is 1.8 million. That is per month.
I think, Honorable Lulume, you're confusing it with the money for medicines for health center 2s and 3s.
No, that was a PHC fund at the time. So if at all it was increased by 50%, that was 1.8 per month.
No.
And that would only be enough to pay for electricity bills and sometimes part of water bills and slashing.
No,
for maintenance.
You're confusing figures of health center 2s and health center 3s.
I've been to hospitals where, you know, in the operating theaters, those lights up there, some lights are not even working, and you're wondering how is somebody even going to operate on this table. And then those beds, I saw a hospital where it was tilted to an angle, but still the Ugandan health worker, trust me, they can still save lives there. I went to a place where you know, there's total breakdown. Do you understand the brokenness of our state institutions is really disgusting?
To tell you the truth, one of the challenges that we had that made our equipment be in that state was about maintenance, repair and maintenance. Because over the years, we concentrated on training the medical personnel hands-on, and we did not concentrate on biomedical engineers to maintain our equipment. However, currently in the country, we have Chambogo University and Mbarara University training biomedical engineers. These biomedical engineers are now being deployed in the various facilities. You need to take another tour and you see the changes that are happening. The equipment are being repaired because some of the beds that are broken only need to be welded and they get back into being good beds. You weld, you respray, and it is brand new. But we are generating items that could be repaired, putting them aside, leaving them outside to be rusted because of lack of biomedical engineers. Thank God that now we have nearly over 150 biomedical engineers in this country that can be deployed to do these repairs.
You know, I've seen, for example, government or district ambulances, you know, parked at hospitals.
With only one tire.
With only one, and some, with the grass growing under them. And I've also I've seen where ambulances work, but if you want to use it, perhaps you'll have to buy your own fuel. You know, I mean, the challenges are immense. And this is your docket, Dr. Cheng.
Yes, the challenges are immense, but the challenges are not insurmountable. What is required is for all of us to be committed to addressing those challenges. I will tell you what we are doing about the ambulance system. Because over the years, we believed that if you give facilities ambulances, they will be able to run it and maintain it. But running vehicles is extremely expensive. It is a recurrent expenditure that never ends. And that was not the right planning. And I am glad that we all realized this, and government said, can we have a proper, well-studied ambulance policy and strategy? That is already in place. Now, this ambulance policy and strategy allows for ambulances to be available per region, a huge number of ambulances in every region, with call centers in the regional referrals. And the ambulances will not sit in the districts. They will be on the highways and in the facilities where they are needed. You just have to call and an ambulance will come and take you. But that
glorious plan has been on the shelf for a long time.
This glorious plan
that is never put into
needed to be put into policy and strategy. And that has just been concluded. It is now going to Cabinet for Cabinet to consider it. And then it will be, you know, passed and we start implementing it. Already, we are running pilots of this policy in a number of areas. In the Rwenzori region, in West Nile region, and recently, if you have been following me on social media, in Masaka and Bukomansimbi.
Take out Baila in the Rwenzori and there's no health system there.
Baila was supporting government, and government is running its business there.
But you know, Baila is a big thing. If you really get them out.
I am telling you that Baila was supporting government, and government is in there. The funding that is supporting the West Nile and the Rwenzori region was coming from Enable, from the Belgium government.
Dr. Cheng and Dr. Lume, we're going to take a break. When we come back, I'll also open the line so that Ugandans who are going to use this National Health Insurance Scheme, probably they will ask some questions and maybe give their contributions. We'll be right back. Welcome back. You're watching On The Spot. My name is Patrick Amara. My guests tonight are Dr. Jane Ruth Acheng and Dr. Lulume Bayiga. We're discussing the National Health Insurance Scheme that is being proposed in a bill. I know, for example, we're already paying a lot. You know, pay as you earn. We pay, of course, an NSSF, which is not bad. In some cases, local service tax. And we're being taxed left, right, and center. And very soon now, we are going to put the 4% or whatever is going to be agreed to be deducted. And yet, all the taxes that government collects, you know, we expect as a government, when you collect taxes from us, including pay as you earn and all this kind of thing, you put this money to use and you provide an effective healthcare system. You don't have again to put a burden on us, because you already, on everything there's a tax.
Yeah, there was a statement which the minister was making, that healthcare all over the world is not free. And people are not really yearning for free things because they pay taxes in order to ensure that government does something for them. Otherwise, they wouldn't have paid taxes. They wouldn't have paid taxes so that government, if at all you want government to impose that we are giving you something, then the people will not pay taxes. But if at all the people pay taxes, then government is not giving health care free. It is paid, it is prepaid by the taxes that people make. The allocation is where the problem is. And where we want to help the Minister for Health, as in the private sector, civil society organizations and so on, is for you to say, please help me to ensure that I raise my budget from this to that. And that will be the only honest thing any minister can do. To campaign for you so that government realizes that they must invest more in health to refurbish all this that we are talking about. And it is not, we cannot hide our heads in the sand. All hospitals lack leadership, you have said it. Governance problems, accountability, and so on. And of course, the decentralized system, as you know, makes you handcuffed in order to reprimand healthcare deliverers at the grassroots level where the people are. And if that happens, then you cannot address the rot at the grassroots. For somebody who is going to pay 100,000 in an informal sector, expecting to find something else when you have got unamended systems, or even when they are amended, but you are not capable of ensuring that they function, then the people will negate the law and it will be on the shelves and stale.
True. And you have made a very correct observation. But again, I'll take you back to what I said. the facilities will have to be accredited and they will have to change their ways of running things. It is true that the health sector needs more money, but it is also true that there has been a progressive increment on the health sector budget. I started by saying we run a cash economy. What we collect is what we expend. And I clearly told you that the 7.3 trillion of the health sector could nearly be 1/3 of the total collection of the entire country.
Doesn't that also include the 41% from out of pocket?
Yes, it includes the 41% of out of pocket.
That's what you to make it 7.5 trillion.
Yes,
yeah, but
exactly, and that is why we are saying.
And include the donor.
Yes.
Yeah, but please, you are stretching it too much because.
So we should be talking about the 15%.
15% of what you put.
Exactly, and that is why I am saying government has been making increments. It cannot jump all of a sudden to that amount of money if you're living on a cash economy. We are relying on revenue. So there has to be a streamlined way of addressing this 41% out of pocket, because the 41% out of pocket is varied. Not everybody pays the same amount. You may go to an expensive facility and you pay 5 million. Others will go to another facility and pay 100,000. So why don't we pool that resource together through the health insurance and ensure that everybody, there is equity in distribution of services?
Why don't we target the people who pay most? Because when you are aggregating it, you are also taking into account those people who pay 1,000 to get a Panadol over the counter.
Mm-hmm.
You are also taking into account somebody who is paying 2,000 and so on.
Yes.
So we can make it in an organized way, because when you're talking about 41%, which is spent out of the pocket, it is not realizable anywhere. You cannot see it.
No, you can't see it.
Yes. How to mobilize it is where the problem is. The statistics should show, in order to back this bill, that we have these taxpayers that we are going to target. And they should be willing to pay for those who are unable to pay.
You can't say they should be willing
We
to
can
pay.
incentivize it. We can say that you have been giving this.
Mm-hmm.
Well, if at all you pay for the national health insurance, which is going to cater for how many people downstream who do not have the money to pay, the indigents. And I believe in Uganda they make over 50%. But as who goes through our constituencies,
I hope you are prepared for the backlash that is going to come. People who are going to say no because they look at this as a tax and they are not sure whether they put in this money are going to give them effective healthcare system. That's another thing. And I hope you're also aware that we're entering into a political period, campaign period, and most likely the chief executive can easily say, you know what, I didn't understand this very well, so let's pull it.
You see, when we prepared this draft bill, the process started in 2002.
It has been on for 17 years. 17
years of trying to address all the loopholes, address the gaps, you know, have scenarios of calculations, look at this and that, discuss with Ministry of Finance, get consultants, rediscuss, and so on and so forth. So we have the statistics to share with people how we arrived at some of the figures that you're seeing here. That
okay,
is
the question is,
Two.
Dr. Cheng, the question is, what is the percentage of the Ugandan population, well-to-do population, that is likely to be tasked to pay for those who do not have enough money to pay for health care? Because the principle is those who have work in solidarity with those who do not have in order to provide for them.
And that is the principle behind
so we
health insurance. It is risk pooling.
Yes, we should be able to say we have so many people who we are earmarking to finance the health care for those who are unable to pay.
Who are about 45%.
The people who are unable to pay?
The people who are able to pay.
45%?
Yes.
45% is an overestimation.
It is that is the number of the people who are able to pay. Don't look at somebody in the village and you say this one is not able to pay. Some of them are good farmers and they're able to afford the 100,000 we are talking about.
Anyway, those
Now,
are the 41 out of pocket, even plus a few others. So I think you could be right on that one.
Yes, so the principle behind risk pooling is that you make an assumption that when you pay your money, you are not going to fall sick all the time to utilize that money. And you know very well because you yourself are insured. If you don't go to a facility in 1 year, that money doesn't come back to you. It belongs to the insurance scheme. And that money over time is generated into some good amount of money that will be subsidized by government to cater for the indigents. That is why we are saying, let the indigents not spend money. Because right now, we are driving them more into impoverishment. And they are not coming out of it. Because every time they fall sick, they have to go to a facility and look for money, even to pay for diseases like malaria. They are the same people who are not using the bed nets. All of you within Kampala, you have your bed nets. Even when I come to distribute bed nets to your houses, door to door, you tell me you already have. The people that I give bed nets to are not using the bed nets, and they are the same people continuing to fall sick. So the only way to support them is to have the health insurance system in place.
Okay, I hope that works, and I'm going to open the line so that you can be able to be a part of this discussion. The numbers are going to be showing on your screen there. Please tell us where you're from and give us your name and be precise and concise. Should you maybe disagree with the Honorable Minister or Dr. Lulume, well, you can disagree honorably. That's how we do it on this table. So that, especially when you disagree, that you have to be civil. So you think...
Hello?
Hello?
Hi, Patrick.
Good evening, sir. What's your name and where are you calling from?
My name is George. I'm calling from somewhere near Lake Victoria.
Near Lake Victoria. Go right ahead, George.
Yeah, I think the minister is really joking here. Yeah?
The minister is what?
They have failed to manage the little they have. Hello?
Okay, go right ahead.
So I'm saying that I think the minister is taking us for a ride here, because the minister is taking us for a ride because the government for almost 20 plus years has failed to manage basic health with the so-called meager resources they have. How then will they manage the bigger stuff they tend to get from us by taxation? Ambulances are rotting, one tire, grass under there, beds are falling apart in hospitals. You can't pay health workers. I mean, you think you can convince us to give you more money to dump in your pocket? I don't think it's right. I think you're following the path of socialism, where, you know, the socialism says everybody works, everybody eats. But in actual sense, in socialism, some will work and all will eat. So I think your health system should cater for, I'm willing to pay as a person who works, I'm willing to pay for emergencies. But I'm not willing to pay for guys. I'm not willing to pay for guys who do not want to work. Yeah, you understand? So okay. I think the government should focus on improving the economy so that people can be out of poverty, pay more taxes, and then the health system can work, maybe. But don't tell us now that you should pay more. We're already paying 30% plus in taxes. Now you want us to pay 34% in taxes. Next time you come back and say, no, we're going to use universal health education, add another 4%, it should be at 40%.
All right.
It doesn't work like that. Yeah.
George, thank you very much, George. Your point is made and your point is taken. I'm going to try and take another caller so that the Honorable Minister can respond to you at once. I have a call online. Hello.
This is Robert from Bushenyi.
Robert in Bushenyi, you are on air, Robert.
Yes, I would advise our Honorable Minister to go and consult from Rwanda how they are doing it. Because in Rwanda there is that policy and it's working on mostly.
Are you sure it's working smoothly?
Secondly, why can't they bring that policy into education? Because also the cost of education is also going high. You cannot have private hospitals running, then you expect the government hospitals to perform.
All right. Thank you very much. Our caller there from Bushenyi. I think maybe I can take one more or two and then the minister will respond. I have a call online. Hello. Hello.
Hello.
Good evening, sir. What's your name and where are you calling from?
My name is Okolmoy. I'm calling from Kampala.
Go right ahead, Okolmoy.
Yeah, my question is really directed to the Honorable Lulume.
Okay.
Yeah. How will we make sure that the money that is contributed from the national insurance does not affect the actual allocation that's currently being put by the government to the health sector? Because there is a tendency for government to now become complacent and say, we're getting money from health insurance, so we are not going to increase. How are we going to ensure that doesn't happen?
All right, thank you very much. Thank you very much for that question. And so I think my producer is telling me there's one more. Okay, quite a number of you would want to contribute on this, but it's a bit question of time. Hello?
Hello, Patrick Kamara.
Good evening, sir. What's your name?
I'm Byron calling from India.
Byron, you're on air.
Now, I happen to have been on some insurance scheme.
Okay.
And when you go to the facilities that you are on insurance, they don't attend to you because there are those who are not in insurance and they come with cash. Now, if I am on insurance, like the government, the ministry is saying, how sure am I that if I'm on a line with someone who is not on insurance and has cash, those health officials will attend to me?
Okay.
Thank you, Kamara.
Thank you very much, Byron. And the minister is going to respond to you. Yes, Dr. Cheng.
Well, first of all, allow me to appreciate all those who have asked questions, very important and pertinent questions. And the first one came from George, who says we have failed to manage our health facilities with the little resources that we are being given, and how do we think we shall improve when we are given more? First of all, I want to tell George that yes, we've been given money to manage the health facilities, and we are doing it absolutely well with the little that we have. However, the population in Uganda continues to grow every year, and as I have been mentioning here, we are spending $53 per capita. We need more so that we can improve on the services. You need to realize, and this is a fact, that people do not appreciate free things. They do not value free things. So the same me and you who go to those facilities are actually the people who participate in destruction of some of the properties in these facilities. But when you are paying money through insurance, you will value it when you're receiving quality services. And we need to generate this revenue to improve on those services so that when you get there, you will be served accordingly. It is true that our neighbors are already running insurance schemes. By the way, it is only Uganda in the region, in the entire East African region, that does not yet have an insurance scheme in place. And I want to appreciate Robert, who talked about Rwanda having an insurance system that is working. And many other countries, Ghana has an insurance system, Nigeria has an insurance system in West Africa, many other countries do have it. And for some of them, it is for those who can afford and wish to join insurance schemes. For some of them, it is mandatory for the entire population. It has taken us 17 years to think through this insurance system, debate it, have input from stakeholders, and have all their inputs considered, including studying the system in Rwanda. So by the time we come up with a draft bill that will be subject to debate in Parliament, it means we have gathered enough information. And we are ready to go and defend what we have written there. How will we ensure that government expenditure on health does not reduce? I think this has again been approved by Cabinet, that government will continue to fund health, even as we continue enrolling people onto the insurance system. The two will go hand in hand. As more enrollment into the insurance system is achieved, government expenditure also goes down, because government will contribute into the insurance scheme to help subsidize those that are not able to pay. So there is a government commitment towards that effect. Now, on the issue of not being attended to when you are insured, and then people are attended to when they come with cash, that is exactly what we are trying to address. Because with insurance, you prepay for your services. And we want to discourage people from coming with cash to the health facilities. Because when you come with cash, we are still going to call that out-of-pocket expenditure. You are paying for services there and then. So somebody is attracted to your cash, whereas the person who is insured has already prepaid. So you deserve your services even much quicker because you prepaid yourself for those services. That is why we are saying this national health insurance should be mandatory for everyone, so that we avoid the aspect of walking into facilities with cash in our hands and disadvantage those that have prepaid. So that puts us all at the same level. There will be equity for everyone. And the services you demand for should be of the same quality wherever you go.
Okay. Dr. Lume, there's a question for you as well.
It is very uncertain how government is going to respond, especially if at all this bill is enacted into law and there could be some free flow of monies into the coffers of government through the scheme. It is not unlikely that this government may withdraw the funding that is necessary to run the healthcare system, because we know what the NRM government has been doing. But I want to emphasize the following things. Number one, the population must be engaged on this bill. People need to be sensitized about the principles that govern insurance, what pooling of risks means, what the solidarity means, where the poor, the rich subsidize the poor, the healthy subsidizing for the sick, and the young subsidizing for the old, and the benefit there is in these principles. It takes time. I have been in Parliament. Parliament has a scheme, a health insurance scheme, and I know how members of Parliament don't even appreciate what insurance is all about. When somebody does not fall sick in a year, you think that you have been cheated. You are lucky for not falling sick in a year. But somebody else, your friend, your sister, your relative, a beneficiary, could have fallen sick. And what you have put together has helped somebody to maintain his livelihood. So the population must understand why insurance must work and why the healthy must put their monies together.
Help the sick.
To help the sick.
Okay, our time is out. Dr. Lume, what is going to be your concluding remark very briefly?
The National Health Insurance Scheme is not necessarily a magic wand to the problems that are afflicting the healthcare delivery system in Uganda. I believe it is a step in the right direction. We must discuss it. We must engage the population, because the population is the one which is going to trust government. Government must be trustable. If at all government will not be trusted with the funds, the people will resent. Government must be trustable. The health facilities of government must be functionalized. the health workers must be happy and very well motivated, trainings done and deployed, so that the population gains confidence that the facilities of government will work, even the private sector facilities will also work. Otherwise, these funds will end up in private practitioners' hands.
Thank you.
Of which I will be personally happy, as the Society of Uganda Private Medical Practitioners, we shall be happy, especially if at all the accreditation is done fairly, to make it inclusive, standards set for all of us, and to ensure that the system and the fund works.
All right.
For the private sector, we shall be happy with the fund.
Thank you. You have made a
The
pitch,
bulk
haven't you?
will be done by government, which needs to improve.
Thank you very much, Dr. Lulume. Your parting shot, Dr. Cheng.
Yes, first of all, I want to appeal to the people who are giving information to the public to give the correct information. The National Health Insurance Bill is still a draft bill that is yet to be debated by Parliament, and some amendments will be made. The bill, or the draft bill as it is now, will be communicated to the public. The public will be engaged. For the last 17 years, we have been engaging the public. But things change. And there are many other things that we have borrowed from many places that could have changed. And so we shall continue engaging the public and sharing correct information. But at the end of the day, National Health Insurance is one of the health financing mechanisms that can greatly improve a health system of a country and ensure that we move towards universal health coverage, where people are protected from catastrophic expenditures that pushes them into poverty. And I do wish that the population understand the basics and the principles behind a national health insurance scheme, taking the example from the countries that are already running it.
Thank you very much, Dr. Jane Ruth Acheng, the Minister of Health. Thank you, Dr. Lulume Bayiga, former MP for Buikwe and former Shadow Minister of Health. And we thank you all of you who have sent in your views and your questions. Like the Minister has said, the bill is going to be brought to Parliament, so please talk to your members of Parliament, see those relevant committees, maybe go to the gallery and put your contribution there. Perhaps you will make it better, because you also have a mandate to add to that bill when it is coming, when it is already before debate, when it is for debate in Parliament. Thank you very much. We appreciate your insights on the matter. Good night and God bless Uganda.
Thank you.
Thank you.